Next is going to be my longtime friend and our chief of cardiology, Bill Zoghbi, and Bill's going to talk to us as how do you evaluate prosthetic valve function?
All right, since we're talking about various ways of putting in different prostheses, let's talk about the challenge that we have as imagers, as clinicians, as even interventionalists. How do you assess these valve function? A priori, you know that you're dealing, unless you're dealing with all these valves except the one on the at 3 o'clock, all of these are rather stenotic valves, one way or another. So milder stenosis, maybe compared to others, and Mike already has shared with you that the performance of these percutaneous valves is really quite impressive, actually better than we've ever seen with prosthetic valves, really, looking at these gradients and these velocities. So yes, we have a challenge. We have all these different kinds of valves, and you just figure out the number of models and sizes and everything else. Point number one today, for any of you, irrespective of what you're doing, imager, etc., these are the three crux material information that you need to figure out what these valves are about. One, size matters here. The smaller one, you're going to have a higher velocity, higher gradient for the same flow. Two, you need to know what the valve type is. Remember that all these patients usually carry in their billfold, they carry something about their prosthetic valve that was put in. So you should be able to, as a sonographer, whoever is imaging these individuals, to take it and put it in the report so that it is carried from one report to another, to another, to another, so you don't have to ask that question every time. Three is you have to incorporate flow rate, because we know lower flow will carry lower gradient. It doesn't mean that the valve function is different. So this is the basis for any of your evaluation. Point number two, which is not as dramatic, is that depends on the type of valve that you have. It may alter the signal of your non-invasive way of imaging, particularly with Doppler. And what I'm talking about is the bileaflet valve prosthesis, where there is basically a higher velocity across the area between those two leaflets. And that has been demonstrated in vivo, in vitro, you name it. What does it mean? It means by Doppler, since you cannot differentiate the velocities among these orifices, that your determination is that of the highest velocity. It doesn't mean that this is the average velocity across the valve. It also means there is an overestimation of the gradient if you compare it to an invasive measure. And that overestimation is about 30% and can be even more if you have a smaller valve, so a 19 millimeter valve compared to a, let's say, 23, and can be even more if you have a higher flow rate. So the worst overestimation and the most challenging is the one with a very small valve in a high flow situation. Okay? Now, how do we circumvent this? We circumvent this by publishing data, and this is the guideline that was put together, and I had the privilege to chair it back in 2009. I'm not volunteering to write a revising portion of this one, and actually there won't be any. They're not planning any. What there is in the make is, most likely you'll see it next year, is one on percutaneous valves and the challenge of regurgitation wherever you put a percutaneous valve. So the bottom line for you to know, or at least have a feel of whether these velocities are much higher than normal, are to go to the various tables of these valves, because they already incorporate this overestimation of the velocities and the gradients. Okay? So what is needed from a clinical information when you evaluate such patients? You need to know the date of valve replacement, type and size, height and weight and body surface area. And remember, for body surface area, unfortunately, because of the obesity epidemic, whenever you start thinking about prosthesis-patient mismatch, if you divide by a large number, you'll make most of these valves prosthetic mismatch, and it's not. You start thinking about prosthetic mismatch of a gradient if the velocity and the gradient are high to start with, and then you have to think of how large is this body surface area for the height of that individual. What's the BMI like? Symptoms, blood pressure and heart rate, very important. So let's go through some of these valves. The aortic valve first. This is a bileaflet prosthesis in the aortic position, and you're going to see a higher velocity than normal. Normal usually is less than 2 meters per second, so this is about 3. And you'll see this valve and say, well, is this a normal prosthesis, yes or no? Okay, so we talked about the 3 factors, okay, that influence the velocity and the gradient. So I've already told you about 2 factors. This is one type of valve, St. Jude Medical. Valve size and watch the difference between mean gradient, and that will be the same difference between velocity and everything else, which you already can infer that what's important there is also this 3rd factor, which is flow across the prosthesis. So take a 19 valve. In this normal population after prosthesis, it can range between 10 and 25. Just imagine. So it adds to complexity. And this is where some incorporation of flow comes to play for you to be able to narrow these differences. And when you use the continuity equation, same thing that you'd use for a native valve, you end up for the same cohort that you just seen, that from a 19 to 31, much tighter, if you will. However, notice also because of this overestimation, effective orifice area becomes rather small for a 19 valve. Can be even as low as 0.75 or 0.8. It doesn't mean that the valve area is indeed that low, but this is because of this overestimation of velocities, and this is what's normally published in the literature. Now, there is another index that we proposed many, many years ago, is the Doppler velocity index. And why is that important? That's important because it's simplistic to start with and works even maybe better than an effective orifice area in general if you don't know the valve size. Simplistically, it is what happened to this velocity when just from before to after the prosthesis. It will accelerate. So therefore, this ratio will be always less than 1. So in a best situation without a valve, you'll end up with 1. So it will be less than 1. And vast majority for a St. Jude prosthesis is about 0.4, 0.5. Now, interestingly enough, Mike Rearton just told you that the performance index of this DVI is so much better than in percutaneous valves, and indeed it's so much better. We have normals that certainly are above 0.5, meaning it will just accelerate 2 times across the prosthesis, and many of them, it barely accelerates from pulse Doppler in the alveolar tract to through the velocity. So that's very important, and that's very encouraging because the performance of these valves is tremendous, conceivably telling us also about longevity of these valves because there is less turbulence, and we don't know that compared to the surgical implanted bioprosthetic valves. So remember that the velocity across these percutaneous valves increases much less. It's almost like a normal valve coming through. So what do we look at when we look at evaluation of these prosthetic valves? Normal is on your left and an obstructed valve on the right. Let's notice a few things that are important. One is, yes, we know that the velocity across it is much higher, so it's 5.5 meters per second in this quite impressive situation. 2 is this acceleration time that you see there, and the acceleration time is from the onset of ejection to maximal velocity. Ideally should be less than 80 milliseconds. And whenever you have obstruction, it takes time for the maximal velocity to be there. And this is more than 130 is very specific for obstruction. You start wondering about it if you're close to 80 or 100 milliseconds. Notice another thing. The contour is much parabolic. That's similar to severe aortic stenosis, the native valve, because it takes time for the maximal velocity to get there. And last but not least, prolongation of the ejection time, similar to a native aortic stenosis. So these are the things that you would look at when you're evaluating a prosthetic valve, irrespective of what kind of prosthetic valve you're dealing with. Now, this statement is crucial, and we do that already clinically all the time. Why? Because each individual has their own if you will, fingerprint on these valves. There is always variability, and you'd like to have a baseline examination. Ideally, the baseline exam is about 2 months down the line. But this is the ideal world, and we need an echocardiogram most often early on to assess the outcome, be it surgical or percutaneous valve. Particularly in the surgical area, is you always evaluate before somebody goes home, what's the ventricular function like? Is it depressed? Do I need to change my medications? Is there a pericardial effusion? How should I, modify my management? So therefore, always you're gonna have one before discharge from a hospital, but maybe you wanna repeat it down the line 2 to 3 months to get a true baseline. However, in that baseline, these velocities and gradients probably are overestimated to what is the true baseline because of the hyperdynamic situation. How about mitral? Mitral is a bit actually less difficult, I would say, than an aortic prosthesis. Few things are still important, as we know, just similar to a native mitral valve stenosis, that with and more severity of stenosis, the gradient or velocity increases, this pressure half time or the decay of the velocity becomes slower and slower. But one thing in the guideline we mentioned is that do not estimate an effective orifice area, say similar to native mitral stenosis, using the Hartley equation 220 divided by pressure half time, because it doesn't make any sense at all. Meaning the numbers are all over the place, and at times will overestimate what the size. So use it as an index, if you will, but not to derive an effective orifice area. The best way to derive an effective orifice area is using the continuity equation. So what are the parameters? Maximal velocity, mean gradient. Always report or look for what is the heart rate during this, because this is crucial. Pressure half time, effective regurgitant orifice area, and in the guideline there are various tables for you, suggesting stenosis, or at least, wondering about stenosis. Notice one thing. I've done the 2 valves. I haven't even talked about transesophageal echocardiogram, because you really don't need it. You need a transesophageal echocardiogram if I cannot figure it out at all, if I have some issues, because actually a transthoracic is much better than a TEE. If you're looking at velocities, it gives you many more windows than a transesophageal echocardiogram. And obviously, if you're concerned about an obstruction and different ways of doing it, then you need further imaging to try to define that. Transesophageal is great in the mitral position. In the mitral position, in echo, this was the first time we could see actually the mechanisms of the occluders and everything else. Virtually 100% being able to take a look at a valve. Its mechanism, if it is regurgitant, whatever it is, 100%. On the right side is aortic position. And I think we have to admit in this room that for you to tell a clinician, an investigator, an interventionalist, a surgeon, that a valve motion is normal, I would tell you that no more than 20% of the time that I will feel comfortable that indeed this valve motion is completely normal. So let's forget about egos and everything else. With echocardiography, you're not going to be able to do that. And the reason you're not is you're imaging on the side as opposed to en face. Okay? So what do you need to do? Whenever there's a question about obstruction, use radiological means. One, fluoroscopy, if you still remember how to do that, right? And how do you remember how to do that? You have to be on the side of this prosthesis so you'll be able to see it. If you move them around, you're not going to be able to look at the angulation, etc., and there are published angulation. Actually, probably better things nowadays, so you don't have to take them, is you could use CT without the A or with the A. Okay? CT, you can take a look at motion without giving an angiography. If you want to know the mechanism, whether there is a thrombus, yes or no, yes, you could use angiography if they don't have renal dysfunction, etc. So the recommendation, it is not written in your guideline, and there are not going to be any revision. So you can take it from me, is with a lot of experience and expertise in this, and we have to be transparent whenever we say that. If your question is prosthesis mismatch or obstruction, do not do a TEE first, unless there is another issue that you're looking at. You have to use a radiological, and I say radiological as opposed to MRI, because MRI, you're not going to be able to see the motion. There's going to be a lot of artifact. Regurgitation, few things here. One is each one of these valves have built-in regurg. The one that is problematic is mitral. This one will make or break a lab. And the reason for it is it hides behind anything else that you do, irrespective of where it is at. And this is an example for you. I mean, you could be an imager, expert in echo. You tell me how much regurgitation is behind this mitral prosthesis with so much reverberations there. There's no way. There's no way to tell. But I will tell you how much there is, because there is torrential regurgitation with dehiscence. So for the imager, the echocardiographer, there are a few clues that you could take a look at. They're not easy. Mitral E, mean gradient, rarely the mean gradient is very high, usually is about 6 or 7. You could look at a DVI ratio in a different way. If you have a great ventricle but low output, pulse Doppler in the alveolar tract is low, or in the pulmonic area, somebody in heart failure, whatever it is, but you're not going to be able to do that. So your threshold for doing a transesophageal should be very, very low, particularly if you have any of these. And for aortic, actually, is much easier because you don't hide any of this, and it's very similar to native aortic regurgitation. You know, we're not going to go through all that. It's similar to native AR. You want to look at the mechanism, and this is, you know, the mechanism of perivalvular regurgitation. In TAVR, I know we're talking about TAVR here, it is a challenge. Unfortunately, I've been tasked to take a look at these, and the data is soft, and we're going to have to come up with consensus of what to do with TAVR, because as opposed to SAVR, you're going to have punctate areas. You have the different areas because of where calcifications are or non-full expansion, as opposed to SAVR, where you have maybe a suture that has gotten loose or something like this. Much easier after surgery as opposed to after TAVR procedure. And you cannot use the regular things. You can see all of these are eccentric. You cannot use the usual color Doppler, how much is it filling the alveolar flow tract. And the circumferential extent, that's yes, it's written about, we're gonna write about, but I can tell you it is not an easy one, and it's all over the place. So, and you tell me also how easy or how difficult it is to evaluate these regurgitations that are left after a mitral valve clip. Not easy, but ultimately we have to come up with a consensus for you with whatever data is available, and we encourage the researchers to keep on the research so we can come up with some consensus. So in conclusion, clinical evaluation, know the valve type and size. You'd better know that. Baseline echo after surgery. Transthoracic is the first line. In cases with high velocity gradient stenosis, suspect, compare with previous studies. TE fluoroscopy needed, and particularly for mitral, but for aortic, you need to go for a radiological procedure. And if there is big time regurgitation and you're wondering about how much of that, you could use CMR, just like what Dr. Shah mentioned to you today. Thank you very much for your attention.